This topic of the use of gonadotropines in the management of idiopathic male infertility is a really hot topic. As Dr. Pierre introduced his speech, 15% of human couples are infertile, and male is responsible for at least 50% of these cases. The causes for male infertility can be pre-testicular, testicular, or post-testicular. There are many causes we can discuss for hours, but what is important in this presentation is that about 40% of these men, the cause will remain unexplained. And in my opinion, in the real practice, the percentage is more than that, because in our real practice, we usually look for the treatable causes of infertility. And there are some untreatable causes, but are well-known causes that can be counted among the patients who can be unexplained infertility on the practical basis. Those are the idiopathic group we are talking about today. Treating patients with male infertility can be clear. If there is a cause, if there is a treatable cause, so the treatment will be treatment of the cause. But if there is no cause, so the treatment will be empirical. Empirical in the Cambridge English Dictionary means that it's based on what is experienced or seen rather than on theory. For the empirical treatment of male infertility or male subfertility, we have a lot of suggestions. We start with the lifestyle modification. We can convince the patient to stop smoking, to reduce weight, to do exercise. And then with the medications, we have the aromatase inhibitors, we have the selective estrogen receptor modulators, and we have the antioxidants and the zinc and carnitine and other stuff. And gonadotropines used to be or are key players in this context. To understand the role of the gonadotropines, we will quickly touch the physiology of the hypothalamic-pituitary-gonadal axis, where the hypothalamus is the maestro under the higher control or neuronal control from the brain and higher centers, producing the gonadotropin-releasing hormone. In other words, it's also called the LHRH, the luteinizing hormone releasing hormone. It goes to the anterior pituitary through the portal circulation. The portal circulation is this closed circulation to ensure that all GnRH are reaching the pituitary, the target organ, where the cells produce the LH, the luteinizing hormone, and the follicular stimulating hormone. The LH acts on the Leydig cells in the interstitium of the testicle to produce testosterone, and the FSH acts on the Sertoli cells to share in the process of spermatogenesis, as we will see. This axis is under a negative feedback control by the substances produced by the axis itself. So testosterone produced by Leydig cells induce a negative feedback both on the pituitary and on the hypothalamus, and more on the hypothalamus, while inhibin B or inhibin, which is produced by Sertoli cells, induces its inhibitory effect mainly on the pituitary. One interesting issue that we will need to discuss at the end of the presentation is that there are several GnRH modulators, and one of them is the FSH and LH themselves. At this point, I think it's understudied and needs to be addressed in the context of using the gonadotropines while treating this idiopathic infertility. So this axis is pivotal in the development and maintenance of male reproductive system. From the embryo in the intrauterine phase, it's necessary for the phenotype development of the male sex organs, and at puberty it is essential to induce puberty both by FSH and LH, and after puberty it maintains the endocrine function of the testis, which is the production of testosterone, and the excretory function of the testis, which is the production of sperms. But the actual role of FSH in spermatogenesis is the exact mechanism is understood. It's poorly understood. There are many proofs that it is significant. For example, in the experimental animals, in the rhesus monkeys, blocking FSH receptors resulted in significant drop of sperm count and parameters. Also, in the human volunteers, neutralizing FSH in the circulation resulted in the same outcome of dropping the count and parameters of semen. But on the other hand, in the mice FSH knockout studies, where there is no FSH production, we can still have fertile male mice with this knockout FSH. So FSH is essential for the induction of puberty, but its role in maintaining puberty, maintaining spermatogenesis, needs to be further evaluated. The use of FSH, which is the topic of our topic today, of gonadotropins, FSH or LH, mainly FSH, in the empirical treatment of males with subfertility has been studied several times. But mind you that sound research in the field of infertility is very difficult. To conduct a randomized controlled trial is really difficult. First, for the heterogeneity of the studied population, it's very difficult to end up with one variable to be studied in these populations. There are several factors that can influence the couple's fertility, and mostly more than one is playing role at the same time. So what helped in this direction to make up our mind is a meta-analysis done about 13 years ago, and this meta-analysis reviewed the literature at that time, testing the use of the gonadotropins in this context. And the good news that they concluded that the use of gonadotropins, FSH mainly, has increased pregnancy rate. It increased the spontaneous pregnancy rate, but it didn't increase it for the assisted reproductive techniques. And they found that they need to treat 12 to 14 patients with this method to get one pregnancy. But the bad news that this meta-analysis was only on 4 trials, and it included only 278 patients. There was very big range of definition of subfertility, ranging from maybe 14 million sperms up to azoospermia. So the range was so wide. And at the same time, there was different gonadotropin protocols and doses in these 4 trials. The management of the female partner was again variable, and there was no report on the live birth rate. And the reporting of these studies were randomized controlled trials, but there was no data about randomization, which raised the risk of bias in these studies. So that the authors of this review has concluded that the number of trials and the participants is not enough to draw strong conclusions in this meta-analysis. A more recent one was done about 5 years ago, and it was more comprehensive. The good news again, it was that showed significant improvement in pregnancy rate, both spontaneously and after assisted reproduction. And there was significant improvement in the sperm concentration. There was an improvement, yet not significant, in sperm motility. And it failed to improve the testicular volume. This study, or this meta-analysis, was conducted on 15 trials and included more than 1,200 patients. But again, the same drawbacks, or most of the drawbacks, are still there. They included non-randomized trials. 6 of them were non-randomized. The definition of subfertility was again very wide. The female partner management was different, and they concluded they need to treat up to 18 patients to get only one pregnancy. These authors again concluded that a standardized FSH treatment protocol for male idiopathic infertility does not exist. And knowing that there is no specific predictor of response in this context, so its use should be taken judiciously. And this point of finding a predictor of response I think is a very good message from this meta-analysis. If we know that we will need to use these agents and others in this situation, we don't have a lot of armamentarium. But if we can have predictors of response, we can better manage our patients and save some of them unnecessary costly treatment. In this direction, a more recent, well-done trial, Chinese trial, which is a prospective randomized double-blind placebo-controlled trial, tested the use of gonadotropines in this context, and what they found that they get better results when the inhibin B level is normal or low. So this is, we can consider this as one or the first predictive response while selecting our patients to receive this treatment. On the same track, another trial trying to prove that FSH improves DNA fragment or damage has concluded that there is more evident improvement when the basal DNA fragmentation index was lower than 17, and the FSH level in such population at the lower level of normal. So these can be another two predictors of response, the DNA fragmentation index and the FSH level. Again, and relatively in a basic research manner, they found that the response in the DNA fragmentation response only happens with certain genotype of the FSH receptors. So again, the day may come that we can first identify, by a way or another, the genotype of the FSH receptor present in the patient before starting such treatment. This was for the mainly for the severe oligo-orterato or OAT syndrome. Gonadotropines has also been tried, either the FSH in the idiopathic azoospermic patients, and again the human gonadotropines has been tested in the same context of non-obstructive azoospermia. Actually, the studies are low numbered and they're very few, so we cannot generalize absolutely the outcome. They found that there is some increase in the intertesticular testosterone, the reduction in the DNA in the spermatogonia, but this can't be applied to the clinical practice yet. So in conclusion, or in a pre-conclusion, the guidelines, at least the European guidelines, based on these evidence, which is relatively weak, they concluded a weak evidence that in men with idiopathic azoospermia or oligospermia, FSH values normal, and this I emphasize that the FSH values should be normal when we are talking about these patients. FSH treatment may ameliorate spermatogenesis outcome. And in the context of TC or micro-TC, there is no conclusive recommendations to use the gonadotropines in these patients. I will come back to this point to put in consideration before my recommendations, which is the next slide, that knowing that FSH and LH can exert a negative feedback on GnRH production, we have to be very cautious if we are going to use FSH, whatever the form, in our patients, that there might be a negative feedback of SH on the hypothalamus that reduces the production of GnRH, and consequently LH will be low and testosterone will be low and intratesticular testosterone will be low, and you will be correcting some deficit and creating another deficit. This point is, we are investigating now in my department this issue, and I think it has to be put in consideration if we are using this protocol to monitor testosterone and LH to make sure that this negative feedback didn't show. At the end, I will use the gonadotropines in the treatment of some of my patients, but I will be very clear to myself and to my patients. I need to better select my patients to choose the subgroup that will benefit most with this costly treatment. I will usually start with the less costly management protocols that have maybe, again, suboptimal outcome, but still less costly, less side effects maybe, and can give some results that avoid the use of this costly management. And most importantly, and I think maybe some of our colleagues forget to address this issue, which is very important to me, that we have using such preparations on such basis, we have to properly counsel our patients. Our patients has the right to know what they are going to have, what they are going to spend their money on, and what should they expect out of it. So this is my message, and I hope I can answer your questions. Thank you.